Our next speaker is Dr. Dorai Raj Appadorai. He's a senior resident in general medicine who's very involved in the teaching of junior doctors. And today he will bring us through the new lipid guidelines and how it will impact our practice. Let's welcome Dr. Dorai.
So what I'm going to be talking about basically is an overview of the goals of therapy and management modalities that are available and that we should probably comply with. So we all know hyperlipidemia is basically an elevated level of lipoproteins, be it triglycerides, LDLs, or low HDL levels. So when you have someone presenting to you in the clinic setting with high cholesterol levels, whether it's in a primary prevention setting or a secondary prevention setting, the first thing that comes to mind is we should consider an underlying secondary cause instead of just jumping to the conclusion that this could be familial and that it should be treated. So we should take into consideration possible secondary causes such as dietary causes. We know high saturated fats may cause increased LDL levels, alcohol and smoking as well. Certain underlying medical diseases such as cholestasis, nephrotic syndrome, probably hypothyroidism, which can give rise to high cholesterol levels as well, that we should take into account and probably screen if we think the patient may be having these conditions, especially young patients who come to you with sudden high levels of cholesterol with no family history or preceding history of any atherosclerotic cardiovascular disease. Certain medications, commonly oral contraceptive pills, glucocorticoids, also known to elevate cholesterol levels. So I'll be going straight into just management strategies. So you have a patient again presenting to you in the clinic with high cholesterol levels. What do you advise them? So especially the primary setting, if they come into you with high levels with no underlying atherosclerotic cardiovascular disease, it's important to always advise lifestyle modification first, or what we commonly refer to as therapeutic lifestyle changes. Restrict total fats, restrict saturated fats, probably some moderate increase in mono or polyunsaturated fats to substitute your saturated fats. So we should probably know what sort of foods, such as you have your canola or olive oil that is probably high in monounsaturated fats, sunflower oil and nuts that may be high in polyunsaturated fats, and reduce saturated fats, what you see in basically red meat and dairy products. So the total amount of cholesterol per day shouldn't be more than 300 milligrams per day for normal intake. And increased dietary fiber, about 10 to 30 grams per day is advised. We should advise them to reduce weight in a 3-month setting. If they can achieve a target drop in the BP of about 10%, that will be great. And advise smoking and alcohol cessation. As I said, these are secondary causes that can push your cholesterol levels up, and treat underlying hypertension, diabetes, all of which can lead to metabolic syndrome, obesity, and therefore increase your cholesterol levels as well. So always advise therapeutic lifestyle changes before jumping to initiate pharmacological therapy. Monitor them in 3 months and see if they're improving. And this is more so in the primary prevention setting. So we have a whole host of medications that we that is there in the market that we provide for patients to contain high lipid levels. Probably the most commonest use are statins, which has over the years and through many guidelines, it has established its efficacy and its importance in actually reducing cardiovascular endpoints and bringing about sustenance of life and prevention of recurrence of cardiovascular morbidity and mortality. So we have a whole host of medications from the old age rovastatin, pravastatin, flua, and down to the newer ones, which are atorva and rosuvastatin. And then we have the fibrates, which are also commonly used as a substitute to statins if the patients don't respond or for other particular reasons. Then we have nicotinic acid or niacin, which is not commonly used mainly because of the side effects that it may bring about, such as flushing, warmth, so on and so forth. And then we have the bile acid sequestrants. Again, it helps in reducing the LDL levels, but not too commonly used because of the commonly reported GI side effects. So many patients don't tolerate the GI side effects that come about with bile acid sequestrants listed here. Ezetimibe is a good drug that's come out about 10-15 years ago. It's a cholesterol absorption inhibitor. It's a good substitute to be taken with statin or alone if patients don't tolerate statin. So it's a good substitute for statin. If you're going to give it with statins as combination, you should always look out for potential transaminitis and things like that. And neomycin propicol, probably not really used in our setting either. So these are probably the effects of all these lipid-lowering agents on lipid levels. What I probably need to highlight to you is we have our statins over here, which does help in bringing down the cholesterol markedly by about 20 to 60%, and probably the best among all the classes of lipid lowering agents. It only has 10 to 33% reduction effect on triglycerides, as opposed to fibrates, which reduces the TGs by up to 50%. The fibrates otherwise does not really bring about much improvement in your LDL levels. And then we have ezetimibe, which again has a very remarkable effect in reducing LDLs. Of course, not as good as your statins. Again, it's about 17%, but not much effect on the TGs or HDL cholesterol levels. So niacin here helps pretty much in bringing up the HDL levels, if you notice, compared to the other class of drugs. Omega-3 fatty acids again helps in hypertriglyceridemia, probably as a substitute to the fibrates. But to note, it does increase. There's an outgoing arrow there. It does increase the LDL a little bit by about 4 to 49%. So if you want to prescribe your patients with omega-3 fatty acids, it's probably wise to advise them that it may push up the LDL levels, and we might need to monitor it a bit closer. So this graph basically shows the efficacy of our new agent statins, the rosuva and atorvastatin, as compared to dose-dependent fluva pravastatin seen lower in the graph. Okay, again, atorvastatin and rosuvastatin, as you can see in this table, has shown to reduce LDL more potently compared to the older agent lovastatin, simva or pravastatin by about 39 to 45%. So as I mentioned, omega-3 fatty acids helps in lowering TGs, but it may push the LDL levels up, and it can impact glycemic control. So some patients may report uncontrolled sugar levels once they are on omega-3 fatty acids. So just a word of caution, just to probably monitor the patients closely. So statin myopathy, it's a common concern among many of us prescribing statins, and it's a very real side effect. It's a very real complaint by most of our patients who start taking statins. About 2 to 11%, so that's like probably 1 in every 10 patients that you prescribe a statin for may report some myalgia, muscle ache, and many a times these patients may not have elevated CKs, so they may be coming in with muscle aches. You check the creatine kinase level and it's not elevated, but that's not a reason not to stop the statin. So if the patient does complain of myalgia, we should do something about it. You can either, it's based on patient's preference. You can advise the possible modes of action. You would either stop the statin the patient is on, give him a drug-free period and resume it after about a month or 2 to see if he does better thereafter. Or we can reduce the current dose that the patient is on and see if the symptoms improve. Or we can switch to a lower or an older generation statin, because as we know, atorva and rosuvastatin, being the newer agent statins, have an increased incidence in causing myopathy as compared to the older agents. So you could switch something older like lova or pravastatin. Myositis and rhabdomyolysis is there, but it's probably not as scary as incidence of myalgias. So running into the guidelines, there are a whole host of guidelines by most of the health communities around the world. Probably NICE guidelines is one of the older ones that came up probably 10-15 years ago. And in fact, as we speak, just 2-3 weeks ago, they updated their guidelines. So there is a new lipid update under the NICE guidelines, which was published in July 2014, so just a month ago. And basically, the NICE stresses on a lot of establishment of risk stratification, speaking to the patient, approaching the patient holistically. So that's stressed quite a bit in the NICE guidelines. They used to use a few tools, the Framingham Risk Tool, the ASSIGN tool, which was developed using a Scottish cohort, and the Q Risk tool. So the current guidelines published in 2014 July actually makes use of the Q Risk tool to risk stratify patients with regards to cardiovascular outcomes. As I mentioned, we should always inform patients whom we see with regards to absolute risk of CVD, the absolute benefit and harms of treatment and intervention that can be done over a 10-year period. We should also provide them with information on the risks and benefit scenarios of treatment and not being on treatment. Tell them what their risk score are based on the Q risk or the Framingham Heart score. Inform them, use appropriate diagrams and text. So we want the patients to be armed with information with regards to how they can curtail their own lipid levels and prevent further cardiovascular outcomes. Of course, we advise them against smoking, alcohol, reduce weight, and maintain BP and diabetes. So as of up to July, it was always simvastatin under the NICE guidelines, but they have just revised that, and now for primary prevention, if someone comes into you with high lipid levels, the choice of drug will be atorvastatin, 20 milligrams first, and especially if they have a 10-year risk of developing a CVD being more than 10%. And this score is obtained by the Q Risk Assessment tool that you can just Google on. And even for patients 85 years or older, they've stated an age limit here. Atorvastatin 20 milligrams is the starting choice. Again, in secondary prevention, this is probably more in the tertiary setting. If someone has developed a non-fatal myocardial infarction or a stroke, we start off with 80 milligrams on atorvastatin and probably taper the dose down prior to discharging them. Of course, we have to take into consideration that 18 mg of atorvastatin, there is risk of potential drug reactions, adverse effects, and the patients themselves may not prefer such a high dose because of their potential side effects. Just a quick glance on the Canadian Cardiovascular Society guidelines. It is very much a Xerox of the ATP3 guidelines. There's not much change here. Basically, they risk stratify the patients based on the Framingham Risk Stool score. So if they're more than 20%, 10 to 19%, or less than 10%, there are appropriate treatment targets to initiate therapy, and what the LDL target goals are, and what are the alternate target goals. So this is just a slide to inform you that these guidelines exist, so you can probably look it up at your own leisure. What we have been holding on to for the last couple of years, I would say, is probably the ATP3 guidelines, which is a benchmark guidelines produced by the National Cholesterol Education Program. Till today, we still think this is probably a very good and comprehensive guideline and the approach of management of patients with dyslipidemia. Since its inception in 1988, it has undergone a lot of revisions and updates in 1993, 2001, and all the way up to December 2013, when there was a revision to these guidelines, mainly by the American College of Cardiology and American Heart Association. So this is what was actually out in 2013. But before I go into the revised guidelines, just a brief look into the ATP3 guidelines again. The ATP3 was formulated after having basically looked through a comprehensive meta-analysis involving numerous studies, all of which did show that statins, or probably substitute to statins, had great efficacy in reducing cardiovascular morbidity and mortality in the long run. So these were the studies that were taken into consideration for the ATP3 guidelines. This is just a classification of the cholesterol concentrations and the interpretation, basically. So when do we intervene when patients have these levels? It's all there for your perusal in the ATP3 guidelines. The ATP3 does mention what are coronary heart disease equivalents. So these are patients at higher risk. If you have any of these conditions, you're almost equal to someone who's had a coronary heart event. So that will be patients with diabetes, peripheral arterial disease, symptomatic carotid artery disease, namely TIA or strokes, an aortic aneurysm, and a 10-year risk of more than 20% based on the Framingham risk score. What are major cardiovascular risk factors? Smoking, hypertension, low HDL, and a family history of premature cardiovascular disease. That's in a first-degree relative, in a male of less than 55 years, and a female of less than 65 years. And age alone being a risk factor. So if you're more than 45 in a male or more than 55 in a female, you have a major risk factor. So based upon all these combination of factors, the ATP3 came up with a summarized risk stratification table, whereby if you have a 10-year risk of more than 20% with CHD, or a CHD risk equivalent, you're at high risk. And if you have a 10-year risk of 10 to 20%, you're at moderately high risk with 2 or more risk factors, as I mentioned earlier. And you're at moderate risk if you have 2 or more risk factors with a 10-year risk of less than 10%, and you're at low risk if you have just 1 or no risk factors at all. So depending on these risk categories, they have subjected LDL goal targets. When do we initiate therapeutic lifestyle changes, and when should we consider drug treatment? So this was actually quite a stronghold in the management. Most of us can't, of course, probably remember this table by heart. So we use it as a guide when we have patients in the clinic setting. It's always important to refer back and see where we should probably upset treatment or commence treatment in certain patients. In Tan Tock Seng Hospital, we have our own tool for the risk stratification, mainly taking into account that we have different strata of population here. So we've taken into account the Chinese, Malays, and Indians to come up with risk stratification tool. As we know, the Framingham risk score covers mainly the Caucasian population. So what's new to the ATP3 guidelines? This is what actually was published in 2013, a brainchild of the ACC-AHA revision. So the approach now is supposed to be more patient-centered rather than one treatment fits all. So they've changed the paradigm of managing patients with dyslipidemia slightly to avoid just achieving targets. I'll speak about that in a while. So according to the current guidelines from the AHA-ACC, target LDL cholesterol levels are not as valuable as a more holistic perspective in assessing which patients should receive lipid-lowering therapy. So if you saw the ATP3 guidelines, we just look at the LDLs, and if the patient has a certain LDL level, you want to target it to less than 160 or 90 or 70, so on and so forth. But that's what's being ruled over in the current revised guidelines. So according to expert panel Y, there is simply no evidence from randomized controlled clinical trials to support treatment to specific targets. They make no recommendations for specific LDL or non-HDL targets for the primary and secondary prevention of atherosclerotic cardiovascular disease. So what does the revised guideline basically formulate? They have identified 4 groups of primary and secondary prevention patients to focus on reduction of CV events. And based on these 4 groups, some of them may require high-intensity statin therapy, and some may require moderate-intensity therapy. So I'll show you that in a while. So what are the 4 statin benefit groups? So these are the 4 statin benefit groups. Individuals with clinical ASCVDs, individuals with LDL cholesterol levels of more than 190 or 4.9 millimoles, such as those with familial hypercholesterolemia. So this will be anybody beyond the age of 21, okay, for the second group. Individuals 40 to 75 years old with diabetes and without atherosclerotic cardiovascular disease with LDL levels between 70 to 189. And the 4th group, again, individuals 40 to 75 years old, but this time without diabetes and without ASCVD, but who have LDL levels between 70 to 189 with a 10-year risk of ASCVD of more than 7.5%. So there's always been a scare of targets between 10 to 20 or more than 20, but in the revised guidelines, they brought the target down to 7.5%. And how do they come about with this cutoff? Is actually by using a new tool called the pooled cohort equation as opposed to the Framingham risk tool that was used previously. So the difference between the pooled cohort equation used in the revised guidelines is that it takes into consideration diabetes, which was not there in the previous tool, and it also takes into consideration the racial bias. So there is white, blacks, and others. I'll show you that in a while. So whom do we give high intensity statin therapy to, and whom do we give moderate intensity statin therapy to? The aim for high intensity statin therapy is to reduce the LDLs by 50%, and the aim of the moderate intensity therapy is to reduce the HDL by 30 to 49%. So we're just having target reductions, we're not bringing it down to specific numbers. So when we administer high intensity statin therapy, it will be either atorvastatin 40 to 80 milligrams or Rosuva 20 to 40 milligrams. And why do we give patients high intensity therapy? Mainly to bring the cholesterols down, the LDLs down by approximately 50% or more. And when we prescribe moderate intensity therapy, these are the choices that you can come up with. So lower dose Atorva and lower dose Rosuva, or Simva 20 to 40, so on and so forth. And here the target is to bring down the LDL by 30 to 49% or 30 to 50%. So we are not abandoning the measurement of LDL. LDL is still measured, we're only not chasing targets anymore. Okay, and the best marker of understanding whether patients are going to achieve as much benefit as they can for the dose of statin, we can only tell if they are going to achieve benefit or whether they are improving with regards to their cholesterol control by checking the LDL levels. And for the clinician, it's also a very important marker of adherence as to whether they're compliant to medications or not. So the group 1 are the patients I mentioned earlier. The first group of the statin benefit groups will be those with clinical evidence of atherosclerotic cardiovascular disease. So anyone who's had a non-fatal MI, strokes, peripheral arterial disease, TIAs. In this group, you want to give high intensity statins. So your aim would be to bring the LDL, regardless of what the LDL level is, by more than 50%. You want to reduce it. So even if the LDL is 2.2, but they've developed a ASCVD, we need to start them on high intensity statin to bring it down by 50%. Group 2, these are patients more than 21 years of age with an LDL beyond 190 milligrams per deciliter. Okay, that's 4.9 millimoles per liter. So of course, when you have young patients coming in, we first evaluate for a possible secondary cause and treat it accordingly. But if it's primary or familial, they will require high dose statins. So this is probably this is what has actually got a lot of criticism over the years, or at least over the last few months, mainly because we are seeing very young patients by the thousands or probably by the millions who will now require statin, who would probably not have required statin under the previous ATP3 guidelines. So when they have LDLs of more than 4.9 high-dose statins, or the maximum tolerated dose, okay, and the target will be to bring the LDLs down by 50% at least. The third group are those aged 40 to 75, diabetics with no ASCVDs before. Okay, for these patients, we would probably want to just start them on moderate intensity statins first. But you could use the pooled cohort equation I mentioned earlier to calculate the risk. And if it's more than 75, we could start them on high intensity statins. So this is actually clinician dependent. If the patient is probably not at too much of a high risk, I would still probably start the patient on moderate intensity statins first. And the fourth group are those aged 40 to 75 without diabetes, without ASCVDs, but who come in with very high LDLs. With a PCE, pooled cohort equation of more than 7.5, we would probably want to start them on moderate to high intensity therapy, again based on the risk that you think the patient may develop CVDs. But if the PCE is less than 7.5, you can probably almost start them with just moderate intensity therapy. So this may be a bit too comprehensive. You just need to probably go through these algorithms again, and you'll probably be able to understand it better. So what were the tools that we used to come up with this new pooled cohort equations that come up with this revised ATP3 guidelines? Well, the risk assessment arm of the American College of Cardiology has taken into account a few studies as well as the Framingham risk score to come up with a summarized or what they think is probably the best mode to calculate cardiovascular risk in patients, and therefore we've obtained this pooled cohort equation. So you can probably Google pooled cohort equations, and this is what will pop up, and it's a very easy calculator. So you just key in your patient's particulars. Like I said, as opposed to the Framingham risks tool, this is probably improvised because it takes diabetes into one as one of the parameters and race as one of the parameters as well, which wasn't there in the Framingham risk tool. So it's probably a bit more patient-centered. So what are the critiques to these revised guidelines? As I mentioned, 7.5 now is a lower threshold for treatment as compared to the previous guidelines, which was 10 to 20 or more than 20. And now, in fact, millions of patients who would not have otherwise been treated under the ATP3 guidelines, especially those below the age of 50, will probably now need statin therapy. Okay, the use of pooled cohort equation, we're not probably so used to it, but we probably, if we are really keen to take into account these revised guidelines, it will be good to consider how to make use of these make use of this risk tool. And there is a concern of increased use or abuse of atorvastatin and rosuvastatin to bring down LDL levels by 50%, since we are targeting high intensity reductions in statins in the first and the second group especially, and this may bring about cost issues and of course incidence of myopathy, which is seen more in these two agents. So what if your patients do not fall in any of these four groups? Well, if they don't fall into any of these four groups, you can probably take into consideration other factors. So if these patients are otherwise very healthy, fit, but they have a family history of cardiovascular events among first degree relatives, particularly at a younger age, we might want to consider starting them on a statin therapy. And if they have other markers, you can probably check the C-reactive proteins. You know that if the C-reactive protein is less than 1, they are very low risk. If it's more than 10, they are very high risk. So we can use that as markers to help us. We can probably use the coronary artery calcium score. This again, it's very physician dependent. We don't commonly use these things even in our clinical hospital setting, but these are probably guides that we can use in the outpatient setting to decide whether the patient would need anti-lipid lowering agents or not. Ankle brachial index basically gives an idea as to whether the patient could be having peripheral arterial disease, which again is an atherosclerotic cardiovascular risk, and therefore we could probably decide whether we want to start the patient on some statin. So what do we do when we start a patient on lipid lowering agents? Do we need to check CK? Well, this is guidelines dependent. The NICE guideline says yes, we should check a baseline CK. We should not, we must, we should. If you're concerned, if this patient is an athlete and he does have muscles and pains to begin with, or he complains of muscles and pains in the onset, we should probably just do a baseline CK to probably screen it later or monitor it later if the patients develop newer symptoms later. A baseline ALT is a must. So this is across the guidelines. We should check the ALTs for all patients prior to starting statins, and thereafter we don't need to repeat it unless they come in with symptoms like right hypochondriac pain or jaundice, so on and so forth. If you want to screen it, you can screen it after 6 months to 12 months or so. Wait for them to complain. If they have any muscle complaints, you must check the CK. Probably the best thing to do is to advise them that they may develop myalgias and they should report it. So the follow-up for lipid panels is about 4 to 6 weeks. If you think the patient is compliant and is doing well, then if they're stable after 6 weeks, you can probably repeat it every 3 to 6 months, and in very stable patients, even yearly. So I'm just going to run through a few case examples. In order to decide on treatment strategies, we'll need to use the Framingham risk tool as well as the pooled cohort equations. Since that may take up some time, I'm just going to run through it with you. So we have a 29-year-old male patient who's a physical trainer, non-smoker, no family history, no history of atherosclerotic cardiovascular disease. He has a systolic BP of 118, total cholesterol very high, 7.16 millimoles, LDL of 5.1 very high, and HDLs of 1.9. So if we took into consideration the ATP3 guidelines and we calculated his Framingham risk tool, he's probably less than 1%. So he would probably not be started on any treatment. You would probably just advise him to dietary control. I mean, TLC is definitely the mainstay, but you probably monitor it later. But based on the current revised guidelines, he falls under the second group, and therefore he will need a statin almost at the onset. So this is the group that is probably the biggest group that's going to be affected by these revised guidelines. So we actually, it is not a hard and fast thing that we should follow these guidelines. If you think that you want to monitor your patient and probably ask him to fortify his dietary compliance and exercise and CVAC in 3 months, it's probably okay, with the aim of seeing reductions in LDL over time. Otherwise, he will probably need statin therapy. The case 2 is that of a 43-year-old male. He's diabetic. He's a non-smoker with no family history. Systolic BP of 115, total cholesterol 4.3, LDL of 2.6. So again, if you use the ATP3 guidelines with the Framingham risk tool, his score is only 1%, again very low, so he's at low risk. You probably want to just watch and see. But if you look at the current guidelines, he falls under group 3, and therefore he will actually need moderate intensity statin therapy. So there is, if you notice, there is a very aggressive role of statins in this current revised guidelines. So then again, we leave it to you to decide whether you want to comply with this or probably just stick to the ATP3 and monitor. Okay. And in case 3, we have a 56-year-old male with no diabetes or ASCVD. Okay, so he's got a total cholesterol of 5.8 with an HDL of 1.03. He comes under the 4th group. Okay, in this patient, he has if you look at the Framingham risk score, it's about 12%. If you look at the pooled cohort equation that is now advised in this revised guidelines, it's about 8.7%. So it's almost equal now. So here it doesn't differ much. So even without the current revised guidelines, you'll probably start him on some statin therapy, looking at his age, okay, and looking at the risk score itself. And case 4, this is someone who's 50 years old with hypertension, diabetes, and TIA. We know TIA is an atherosclerotic cardiovascular disease, so he's in group 1. So for these patients, no doubt we'll be starting the patients on statin. With the current revised guidelines, it's high intensity statin. With the previous ATP3 guidelines, it's probably Simva 40 or Atorva 20. So there is an increase in the dose of statin that we prescribe for these patients based on the revised guideline. Okay, so looking into this case, this is a 37-year-old Hispanic male smoker, for example, hypertension on amlodipine, systolic BP of 152. He's got a cholesterol level of 5.2, but his TGs come up being 10.5. So it's good to look at all the parameters, all the lipoprotein parameters to see what is the predominant lipoprotein elevated. In this case, it's hypertriglyceridemia. So with regards to high TGs, there's not much of revision. I think it's probably good to just stick to the ATP3 guidelines. When you have someone with very, very high TGs, always look into possible secondary causes, alcohol, obesity, so on and so forth, diet as well. Okay, and we probably just want to follow what the ATP3 has suggested. So when you look at the levels, if the patient has got a normal, borderline, or high level of triglycerides, we still advocate statin therapy. With the lowering of LDL, the TGs will come down. If they don't respond to statin in the first 3 groups, then you can probably switch it to a fibrate. But in the very high level of TG, that's more than 500 milligrams per deciliter, fibrate is indicated as first line. So we start fibrates immediately. We want to bring it down because of the risk of pancreatitis and xanthometas and all that with very high triglycerides. So where are we now with regards to the future of statins? well, there's not much discussion given into the thought of patients who are beyond the age of 75. As you can see, the revised guidelines just touches patients between the age of 40 to 75, but that will need some more time and years to come, I suppose. And there are new drugs in the pipeline that we think may replace the statins and the side effects that come about with statins or other agents, and these again are still in a lot of consideration. There are a few contentions with regards to statins and other comorbidities that I know that you can probably ask me later, or I can probably clarify with you if you have any doubts. So that will be my talk on lipid updates for today. Thank you very much.